And we're back with Megan Graham, circling the trio of the PT Increst crew. We've had Chris Juno, Jason Torrey, and then the OG. We had Eric. We've had Eric Meta on multiple times.
Eric.
Yes. So I'm stoked that you're here, Megan. For people that don't know you from PT Inquest or your other work, can you just tell the people who you are?
Yes. So I'm a physical therapist, obviously. I probably have a lot of PTs on here. I'm currently wrapping up my PhD at the University of Kentucky. Before I was there, I was at Texas Children's Hospital, primarily working in sports PT, did a lot of work with residency education there. I'm going backwards. I don't usually do this. And then before that, I was also at the University of Kentucky. So I've sort of come full circle from PT school, went out into the clinical world. Now I just couldn't get enough. I'm back in school at UK. So I'm ready to be done, and I will not be returning to school. I promise.
Got it. Yeah. So I initially chatted with you years ago when I was looking at sports medicine residencies, and you were at Texas Children's, or you were about to leave to come to Kentucky.
Yeah.
Why did you go back? Why did you want to go pursue a PhD?
Yeah, this is multi-layered. Clinical care I thought was really fun. I loved it. It challenged me. There was something new every day. After about 5 years, I'm not gonna lie, I was a little burnt out. It felt like, what is my end goal with this? Like, where do I see myself in 20, 30 years from now? Am I gonna go into management, administration? That seems to be the path a lot of people take. And that was just not something I was interested in at all. And I didn't envision myself being a 65-year-old treating clinician. There are some out there, and props to them. They're amazing, but it couldn't be me. And so I really thought about what parts of my job do I really enjoy and what kind of brings me fulfillment and happiness. And with the residency, it was teaching, it was mentoring. And those are the parts of my job that I really enjoyed. Like the residency education part of it was like my absolute favorite part of being at Texas Children's, being able to help new clinicians kind of find their way. And I thought academia, of course, like that is all teaching, education. We all had professors that were old, but it wasn't quite as sad to be in academia and be an old person. So I thought that is something that I felt like I could see myself aging into and feeling fulfilled for a really long period of time. I was looking for jobs like in the middle of the pandemic, which was not great. So I had reached out to UK to ask if they were hiring any like clinical titles, because sometimes they'll hire clinicians to come in and teach. At that time, they were like, no, I mean, if you really want to get into academia, you need to have a PhD. And I was like, okay. So they put me in contact with my current advisor, Brian Noren, and I chatted with him and, you know, what he was researching, which is pretty much all ACL, which is, I'm sure we will talk about extensively today. Even before I started my PhD, that was really my favorite thing to treat. It was kind of like my little passion project at work. And it just seemed like the stars aligned for me to go there, even though it took a massive pay cut to do so. But yeah, that was sort of the path that I arrived upon and haven't really looked back since. So
yeah, so the goal for today is you're nearing the end of this PhD. And before that, you had spent quite a long time in clinical practice, working with residency or residents. And there was obviously things that you probably felt pretty comfortable and certain and confident about before you even started this residency or before this PhD.
Yeah.
And now I just want to have a discussion of what all has changed from the research you've looked at, just the maturity, and as you've aged and as more research has come out, but just now going through academia and all the things that have changed for you in the ACL landscape. And we can take this a variety of ways, but let's start with going into this program. What things were you really confident and certain in, and why, or has some of those things kind of buffered or dampened down in your level of certainty?
Yeah. Well, I will say I thought I was a pretty good clinician for treating ACLs, and then I realized I really was not at all. I was probably pretty horrible. right now, the PhD I'm doing right now is unique because I still treat. We, as part of my graduate assistantship, I have to dedicate at least 20 hours a week to our funded studies. And that can look like a lot of different things, but we do clinical trials. So for me, it's just treating people kind of throughout the duration of rehab. And so I've had so many reps in the last 4 or 5 years with ACLs. I mean, we've probably had 100 come through, and it's all that I'm doing. And so I've definitely gotten, maybe I was confident initially and then I sort of lost it, and now I have regained it in my ability to treat ACLs, particularly that later phase, like 6 months on. Because as you know, in normal practice, even at Texas Children's, 6 months, it was like you're out the door. Either insurance, parents don't want to bring him anymore, the physicians clear them, but for whatever reason, around 6 months, people were typically doing all the stuff on their own, or they're integrating back into sport. So my confidence and my ability to do that return to sport progression, return to performance that happens from that 6 month to a year mark, I feel like has improved immensely. And my ability to test, understand what I'm testing, and being able to tailor the training to help improve the qualities that I'm testing. So strength, RTD, reactive strength, like RSI. We're very blessed to have a lot of technology. So I've gotten very good at using technology and using that information to help kind of guide my rehab process.
What are some things that you were doing before the PhD with treating this population that you just don't do anymore, or the opposite? You alluded to some of the testing, but what things have kind of phased in and phased out?
Yeah, I say the way that we do STIM is a lot different now. Before I would sometimes do electrical stimulation after surgery. Now we do it for upwards of 6 months post-op. The efficacy of, I understand the rationale behind what we're doing now. It's still sort of up in the air exactly the effectiveness of that and how much that changes things. But before I would do it, and it's like once you could do a straight leg raise, we discharged it. Now, if you read kind of clinical practice guidelines and a bunch of Lynn Snyder-Mackler's work, we collaborate with her quite a bit and the folks at Delaware. We wait until they have 80% quad strength to discharge stim.
Yeah. So, can we dive into that? Like,
yeah, of course.
So if you're using it almost all the way up to 6 months or until there's this 80%, what does that look like? And does that evolve over that 6 months and how you utilize the stim?
Yeah. So we do it a little differently than I used to do it. We don't have them do a volitional quad contraction with the stim. So first week or two, we start them just sitting on the table, straight leg, your classic way you think about post-op stim. They're just laying there. But typically I would be like, okay, squeeze with it, whatever. So we do not have them do an active contraction. The stim is contracting it. The thought behind that, and again, I don't know how much specific evidence there is to back this up. It makes sense to me anecdotally, and Lynn will fight you to the death on this for sure. But the thought is that it's recruiting motor units that you cannot volitionally recruit yourself. And so there's a thought that if you're trying to actively recruit and it's trying to recruit peripherally, those can have some competing abilities. So I think of it as an exercise for the motor units that you are not able to recruit during our normal exercise session.
We had, to that point, we had on two, I think they're still in their PhD programs, but two researchers and clinicians out of Delaware. I don't want to blank butcher their names, but we had them on episode 127, their article of Who's Afraid of Electrical Stim. Ilana Arhaus and now Ito. And they discuss the protocol and the setup. And I just go back and forth because I talked with this with one of my close friends in my prior clinic about the setup that we do in the clinic, where we'll have like an NMES, we'll get thicker pads, but then we'll have them utilize like a trigger and actively do it while we're doing an activity. And I know a lot of the setup for the recommendations, like in that group, and some of the research is passively set it up to where it's forcing the limb to kick out a certain amount of their NVIC.
Yep.
And our kind of thoughts were like, in reality, how many patients can actually tolerate that much of a passive volitional contraction? What have you found?
We can get everybody there.
Nice.
And I will not say we have the most like robust, brave, strong cohort you've ever seen. I mean, I think a lot of it you can fudge with the settings. There's ways to make it more comfortable for the patient. But I will say, to your point, I also do the trigger with active movement. But to me, those are like that's working on two different things. Like, one is maybe we're just trying to get the motor control. We're trying to get you to like utilize the quad during, whatever activity we're trying to do. Like sometimes early on, I'll do the trigger with trying to get them to get a short arc quad. And then once they can get it, I'll maybe take the trigger away and then they can still do it. So I use it a lot, that aspect, for like motor learning, as opposed to me, the passive stim is like, I'm trying to just preserve these motor units that aren't getting input until you're able to activate them yourself. So I think there's maybe different ways that you can use stim that have different goals and purposes. So I do some sort of combination of both of those.
In the yeah, it does make sense. But I guess the devil's advocate or argument would be, why, let's say you set them up to an knee extensor isometric, and you're doing 30 seconds, and you set up the stim and it's doing it for them and ramping up into that. What would be the downside of them actively going through it at the same time as the NMES is going off?
I think some of it you could maybe reach an MVIC level that would be not good for the healing tendon or kneecap at that moment. So I think if you had someone volitionally kick with that much stim, you may give too much force through the quad. When you're doing these active ones, you're typically not at that same intensity as we are with like the active one. So when I'm doing like an active or superimposed stim, which is what we call it with the trigger, the intensity that I'm doing that at is lower because I'm getting the additional input from your own muscle, if that makes sense. There's also like with the other stim, like the super strong one, the thought is that we're kind of preferentially recruiting those type 2 fibers, that they're activating first. Whereas maybe if you're doing it yourself, maybe we're not tapping into those bigger motor units quite as quickly or quite as much.
Yeah.
But if you have like a BTB, you may run the risk of a patellar fracture early on if you blast up the stim and have them volitionally kick.
Go a little too hard. Yeah. I asked my buddy that I'm not in the clinic with him anymore, but I consider him a close mentor, and we'll chat every Wednesday morning. And I asked him that question this past Wednesday there was a patient, young female, 5 weeks out, that she was a quad tendon graft, and we were just starting isometrics and we were just utilizing a Tendec, but she was pushing pretty damn hard for 5 weeks out and for her graft. And I asked him, is there a point where I should just like stop it? Or is it still, we're good to go based off of symptom tolerance? But for you, there would be a potential concern if it's maybe too much and it's that superimposed.
If it's super maximal from what their own volitional MVIC would be.
Yeah.
So I probably wouldn't have them maybe kick as hard as possible with the stim. Now, if they do some sort of volitional activation, I don't know. I think there is the thought that there's this, I can't remember the word. Lynn's going to kill me. It's like orthodromic or something interaction where those signals can kind of cancel each other out if there's one descending and one ascending from the peripheral and the central. I'm not entirely sure, but yes. I think there's definitely more research needed in that, like comparing non-volitional versus volitional and how those look differently if they are different. I think we're doing the best we know how to do based off the current literature. But I think that there's a lot of room for things to be better.
Yeah. So big change is doing more for longer in a variety of different capacities with E-stim or with stim and NMES. That
Mm-hmm.
is one thing that's changed. What else has either phased in or phased out?
I think oh gosh, I used to use sort of like preset like jumping programs a lot, like sports metrics and things like that, or running progressions. I'm definitely more free form with that now. I think I've sort of strayed away from template based plyometric and running programs and tailor that a lot more based off the individual and kind of their skill and what they're trying to get back to. I can't say specifically what I do because it's different for everybody, but what else have I changed? I also have started to incorporate, we get like all BTBs. So I do a lot of prophylactic patellar tendon rehab really early on in the process with all of our ACLs. That is not something I was super privy to previously or something that I really thought a lot about. But
Can
we
you
run into issues with like at 6 months, people feel the worst, which is not something that's fantastic.
Yeah, can you elaborate on what that means, the patellar tendon
Mm-hmm.
rehab, or how you go about
Yeah.
that?
So early on, we do a lot of just like prolonged hold isometrics, both with knee extensions and then kind of like decline holds. So sort of your classic, when you look up patellar tendinopathy exercises, sort of those where we just progressively ramp up the intensity of the exercise, both with load and difficulty. So we do a lot where we have like back up against the wall, foot on a decline wedge, and we're having them maintain that position for extended periods of time, kind of getting progressively longer. And we have it kind of pre-programmed to different phases. So we're starting with the isometric, and then we eventually progress to doing Spanish squats with progressive load once they're in the later phases of rehab. So it's nothing super fancy, but we try to do at least like one tendon-based exercise, which it hits the quad too, so it's like a win-win. But something really intentional where we're doing kind of longer duration, either eccentrics, isometrics, throughout the duration of rehab. So
Yeah, do you think that would change if it was a quad tendon or a hamstring tendon? Would there be less of an emphasis, or knowing that this is still targeting, the entire knee extensor mechanism,
yeah,
it's targeting the quad, like would that change much?
I think I would still do the same sort of things with a quad tendon, but try to bias some things with hip extended positions. We've had like 2 quad tendons in the entire time that I've been there, and one was a free tendon. So when they don't take a piece of the kneecap, rehab just like breezes through. It's incredible. Yeah, and probably same for hamstring. I think early on when you don't need to be lifting super heavy or that's contraindicated, doing like progressive isometrics, probably working towards Nordics and things is super critical. We do not get hamstrings, period. So I'm just kind of surmising based off what I could imagine. But yeah, I think the tendon aspect and like training the graft site, wherever that is such a critical part of ACL rehab. So we found it to be helpful with trying to minimize pain with strength testing is like a necessary evil in research
Yeah,
sometimes. So
totally.
we test isometrically at 90 and it will just blow a patellar tendon right up. So that could go into another thing. I do not love isometric testing at 90 for patellar tendons, at least not till like 9 months post-op, because it just really pisses people's knees off.
Yeah, is there a reason you all test at 90 versus isometrically test at 90 versus 60?
Part of it is with research, it's because it's what we've done in the past. And so when we want to compare patients across studies, our patients to other literature, that is probably the most widely used angle and method of testing. Yeah, there's not a lot of moving parts. It's kind of difficult to mess up. I will say I've got beef with 62. I'm using that for one of my studies currently to try to reduce tendon pain, because I think not having the tendon in that more lengthened position, it just doesn't hurt as bad. When you're asking that tendon to flex and then produce a lot of force through it and it's already got a lot of tension on it, that is just not fun for a lot of people. But at least we have a Biodex. It may be different with the Humac, but I find at 60, when there's too much compliance in the machine, to where when they kick at 60, they're actually more at like 45 or less even, because of the way that the arm is. So if I set them up to test at 60, they're actually in a shallower knee angle than that. So that's the frustrating part with 60. So maybe like 75 is the magic number, but I can't mess around with it too much in research because I have to stay consistent.
Yeah, that makes sense.
It drives me bonkers, but perfect world, I'm doing 60 degrees per second isokinetic for maximal strength and doing some sort of rapid effort explosive trials at 90 ISO, because that does not seem to piss people off. It's that like prolonged hold at 90 that really is not a fun one for people.
Mm-hmm. Besides the starting early and progressing with the isometrics for reducing the likelihood of this really getting pissed off later on in the rehab for the patellar tendons, what else, if anything, kind of early phase have you added in or pulled back on, whether it's like things for, strategies for range of motion, reducing certain like amounts of inflammation, anything that you've brought in or brought out?
That's tough. We try a lot. We do a lot of icing. I know people have conflicting things on that, but we do our best just to manage swelling at all costs, whether that's getting people in compression sleeves, icing, like watching step counts, trying to get people, activity modification as much as we can in the early phases. And I think also just being really cognizant of not progressing people too quickly, especially if their knees reactive or swollen. We will hold people from running or jumping for probably longer than a lot of other people might if they're having like persistent, grade 1 or above swelling in their knee. So we really try to hold people based off of symptoms, maybe even if they're not feeling horrible. But I think progressing people too fast is definitely where I see a lot of people make mistakes. Like they're running and I have no idea if their strength is, their knee swollen, they don't have full range of motion. And it's like, once you start running and doing plyos, all the strengthening takes a back seat. So I think or at least now, I'm a lot more objective with my decision making on when I kind of progress people through those earlier phases of rehab. I've never seen anyone do worse by taking a little bit longer to get there.
Yeah, trying to rush into things in a lot of rehabs just generally doesn't end up being a good idea or a good outcome.
And patients get frustrated, but I think as long as you're telling them why, like this is the criteria we need to meet, and once you do this, we can do X, Y, Z. But I think it's it's very patient to patient dependent. So we can talk about that too as well. But
yeah, what else? What do you want to dive into? What all has changed?
Yeah, I think so. We collaborate with Muscle Biology Lab with a lot of our research, which has just absolutely blown my mind. As a PT, like we don't dive too much into like cellular level things, or at least I try not to, because it's, it's a lot. It's like, wow, I don't remember glycolysis. I used to at one point be able to, name the whole thing. But since then, it's like, as I progress through rehab, I feel like my lens gets bigger. I'm seeing things more whole picture. And then to sort of bring things back to like a micro level has been really interesting. And I remember within the first few months I was there, we had a joint lab with the muscle biology lab. And so a bunch of our subjects, well, all of our subjects in our clinical trials get muscle biopsies. And they do a lot of really smart things with those biopsies. They, for my mind, like fiber size and frequency, of course, that makes sense. But it's like the other things that they're looking at that have been really interesting with all of the different changes on a cellular level that happen after an injury, like especially ACL injury, something intra-articular. But there is this entire cascade like of metabolic changes that happen solely within the quad, which is really interesting. Hamstrings not affected. Other muscles, fine. It's like the quad specifically has, a upregulation of myostatin and these other things that really dampen the muscle's ability to respond to resistance training and to atrophy at a really high rate. And so before I would think of atrophy after surgery in more of a disuse atrophy. Okay, you had surgery, your muscle's small, we're not using it. But it's different than that. And it's being driven by a cellular process that we have no control over. And so that was like mind blowing to me because, yeah, it's like we're up against something that one, we don't fully understand. And two, I have no power to really change it at this point. And so I think that has been really eye opening to me because we try to treat this muscle atrophy using hypertrophy related research that's been done in healthy people. And it's like, it's not a healthy muscle. And so it's, yeah, I just don't feel like strength and conditioning literature fully really applies to ACL rehab. I think it's the best that we know how. But I think it's going to be really interesting to see in the future if we can kind of replicate some of these strength and conditioning studies in ACL muscle and see, are we missing something? Like this muscle's not responding typically to hypertrophy training or strength training, or it's like just taking freaking forever. And so it made me feel a little bit better because I feel frustrated when I'm like, I'm doing what I know works and it's not working. And it's like, it happens worse in some people than others, and you have no idea who it's going to be.
Yeah. Do you still, you alluded to it, but you're still utilizing kind of the principles and what the research suggests for general muscle building and hypertrophy. Yeah. And is it just the now kind of acknowledgement that, or reassurance that, okay, it's not because I'm messing up like the parameters that we at least know at this point, it's because there are these other factors that are kind of not within my control. Is that how you kind of look at it, or are you trying to add things or tweak things to try to move that process in a more efficiently?
Unfortunately, I can't tweak it too much because everyone has to kind of go under the same, at least similar template of rehab at this point. And of course, like we do see people get better. We use these strength and conditioning principles and we see hypertrophy happen. We see strength happen, just maybe not at the rate that you might expect it to happen. So I think it's been helpful for me. I haven't really been changing anything. I don't know what I would change at this point other than they need to develop biologics to kind of help this process along. But yeah, I think it's an understanding that some people are going to have a tougher time just inherently. And I don't know who that's going to be. You can usually see within the first week or two of rehab who that's going to be. And those people are behind at 6 months, unfortunately. And some people come in post-op, and by the grace of God, they look fantastic. I mean, I don't know how to predict whose genetic profile and physiology is going to benefit them post-op and who is going to have a tough time to be set back. But I think acknowledging that everybody has a different response to it and just sort of setting the stage for expectations with each person is really important, especially when you've got a room full of ACLs who all look different or maybe at similar phases of rehab. Being able to explain maybe why that is, I think has been helpful. Well, at least somewhat why. We don't really fully know why, but...
Yeah, for sure. Is the goal to kind of start the regrowth and hypertrophy process as quickly as possible and, progress that over time? Is there a strategy that you all utilize? Do you bias towards blood flow restriction? Do you just bias towards higher volume? Like what methods are you trying to achieve this stimulus?
So In the current study, we do not use blood flow restriction training. We did a previous study in it and didn't find any difference between low load and high load training with a real, let's say, real BFR cuff and a sham. So I don't feel like BFR is the answer to fixing things, but I think it could be helpful for situations when people with really bad anterior knee pain, tendon pain, getting some muscle work in a deload week. For situations like that, I think it could be helpful. Like it's basically an additional tool, maybe if you need it, but I definitely wouldn't hang my hat on that being like an answer to anything. We do, like higher volume. We do the APRE where we do a 10 rep max block, a 6 rep max block, and a 3 rep max block. And within that, we have different knee extension type protocols that we use. For in the 6 rep max block, we introduce myo reps, which are disgusting on a knee extension machine. But I've actually seen that be the one thing that gives people a quad pump, which is like, the goal in ACL rehab, to get someone to be able to feel their quad and like actually see it get a pump, which we know, is indicative of that's probably a good hypertrophy stimulus. I'll talk about how we do myo reps. It's
really well, let's first, for people that don't know what APRE is or means, can you just briefly touch on that? And then the myo reps, what does that mean and look like?
I will try not to fudge the APRE. So autoregulatory progressive resistance exercise is APRE. And so when we started this study, I was tasked with make a protocol for a year of ACL rehab that can be the same intensity and volume for everybody, which is quite a difficult thing to try to accomplish. And so the workaround for this, at least for me, I did not want to do 1 rep maxes, especially early on. If you're 3 months out and we're doing 1 RMs to try to gauge intensity, it's difficult and it's painful. And so on the first session of every week, so we do 3 times a week in these earlier phases. So starting around, maybe 8 or 9 weeks post-op, we start this phase where we do the 10 rep max, which we essentially try to do 2 sets to failure. So first set, we kind of guesstimate what your 10 rep max might be. We do a set to failure, and depending on how many reps, we either make the weight heavier or lighter, depending on how many you get. Say you get 15, we make it heavier. If you get 3, we make it lighter, with the hope that by set 4, we have found close to your 10 rep max load. And so based off your...
Can I interrupt you real quick? Are you talking about for leg extension or a variety of exercises?
We do leg extension and single leg press for this phase. Leg extension is always there. And then we choose one quad dominant closed chain exercise. So we start with leg press, and then in the later phases, it moves to trap bar deadlift. But knee extension, always our friend. And then we use that to do a predicted 1 RM. So we put like your weight and your reps into a little nice equation, which of course the higher reps, it's not super accurate, but it's not horrible. And we do 2 different days where we do a higher rep day, so somewhere 12 to 15 reps with like 60% of your estimated 1 RM, and then a little bit heavier day with somewhere around 70-75% of your 1 rep max. And so we do that every week because we know it ebbs and flows, strength changes so much. And sometimes your knee feels like garbage. So it's nice to kind of gauge intensity and volume using that. And then we use that same thing, 6 RM with leg extensions and trap bar deadlifts, and then 3 rep max, same thing.
And then you said for the 6 RM, you'll then add myo reps.
Yes.
What does that look like?
On a different day, because we will not kill people. So we do 1 day a week, we'll do myo reps at 65% of their estimated 1 RM for their leg extensions. The way that we program is so we take 65% of your 1 rep max. You do activation set. So that first set, we tell you to get anywhere from 12 to 15 reps we don't want you to totally go to failure. So maybe leaving like 1 or 2 reps in the tank, and we give you a 10-second rest. And then you go into 4 subsequent sets at the same weight and take all of those to failure as well. And so it'll look somewhere like you do 12 to 15, 8, 6, 3, 2. And early on, we do 1 set of that because it's really brutal. And then later we switch to doing two sets of that entire process.
I think what's nice but brutal about my reps and some of those kind of constrained-ish models is if over those 4 sets, the reps aren't decreasing, then they're leaving so much in the tank, because there's no way that you're going to start at 15 and stay at 15 reps for all 4 sets. It's just not possible.
Yeah. We know when people are sandbagging at that point. And we'll sit next to them. I mean, that's a nice thing. We're in a research study. We have all the time in the world, and we'll sit there and yell at them. You can tell people like fall off that machine afterwards. And they're like, oh, if you don't have that response, you probably didn't do it right. I played around one day with doing BFR Maya reps. I couldn't even do like 2 sets. It's like, do not do this. But yeah, Maya reps, those super kind of like high volume to failure, lighter load, seems to like not piss knees off and give a really, really good quad stimulus. So we try to add that in probably around the like 3-month mark we start. I think you could even start earlier than that.
Let's go into the 6+ months on. You mentioned really early on that one of the big things you've changed is just this kind of late stage rehab and your thoughts. So what does things look like now? What all is phased in and phased out in the late stage rehab?
Yeah. Oh gosh, I guess I never really had a late stage rehab before because I didn't do it. I think my thoughts on the timelines have definitely changed on what I used to think was late and what is late now. Where at 9 months, we have very, very few people passing all the return to sport criteria. If they are, it is our high school kids who had a really easy post-op and just sort of flew through. At like 2 months post-op, you know who's probably going to test out at 9, and you know who's not. So yeah, I think my thought on like a year being, even then, maybe it's like a year and a half for some people, being more late stage. But yeah, I think the progression of strength, the periodization, like kind of working into those lower rep ranges, and feeling comfortable loading, I want to say NARPs, but it's like non-athletic regular people, into that, or like high school kids who have never strength trained before, and really kind of pushing the envelope with how much we're loading these individuals with compound movements like back squats, front squats, deadlifts. Part of that now is I have the resources to do it. I have the time to do it, and I have patients that are willing to do it. So I think I'm pushing the loading a lot more than I was previously. And then also working a lot more on like power-based movements. I hate that word power. That's so whatever. But, we're doing like loaded jumps, a lot of rate of force development type training where we're trying to get people to like move as quickly as possible with load. At least from a strength training perspective, that's been probably the biggest thing that's changed with my late stage rehab.
Are you doing, or is it just tough because the confines of this research setting, are you doing any on-field sprinting, change of direction for the high school athletes or athletes in general, like a gradual return to sport continuum? How do you go about that process?
Yeah. So once people have hit 80% on their strength, we kind of clear them to return to practice. We start doing basic ball handling skills or, things that are not cutting, risky type things as early as possible. So there's no set like template for anybody. I used to think I needed to know every sport and what the demands were, but now I basically just ask the kids what they're doing and what kind of drills they do and what position they play. And we sort of do more of a collaborative type return to activity with parents, patient, trainers. So as early as possible, we're getting them back touching their ball, whether that's just dribbling, passing, setting. We just had a volleyball player, so that's fresh in my mind. we had her serving and passing really early on, like somewhere 3 to 4 months. And then once they hit these certain strength milestones, we kind of send them back into practice with restrictions that we're communicating to the coach. Our space is not great for doing sprinting, return to sport. We don't have turf. So I'm doing a lot more outsourcing and trust with the patient on that end, and giving them just like bumpers for what they can't do. Especially if like coach is doing conditioning, they're doing, they're the sport specific pros at that point, the coach who knows more about whatever patient needs than I do. So I think that's something that's changed too, where I just don't feel like I need to be the person trying to decide like, how are we exactly going to integrate you back into soccer? I can give you the tools and communicate with the coach and let them know what you can and can't do, and let them choose the drills, the skills and things that you need to practice.
Have you had many tears or re-tears since being in the lab?
That's a good question. So in this study, nobody. It's been going on. I feel so bad. I'm going to knock on wood so hard. It's been going on for 3 years and we have had nobody, to my knowledge. And we see these people for a year. So they're like, we have all their phone numbers and we communicate with them not irregularly. Nobody that I'm aware of has been re-injured. I think some of that has to do with how long we hold people, because we get you for a year. I can tell you at 9 months, if you're under 18, I do not want you going back yet. So we hold people from like full contact for a really long time. In our previous study where we only saw people for 6 months, I think we had maybe about a 10% either ipsilateral, contralateral re-tear, which is pretty kind of on par with norms. It'll be interesting. We're doing 2-year follow-up surveys with everybody, one asking if they've had a re-injury, whether they return to performance, competition, sport. And so we're trying to kind of get more long-term data on how these people are actually doing with a full year of supervised PT.
What are the things or the variables that you think are like setting people up for success in the performance? Like, I'm getting back to the highest level that I can, and for reducing this likelihood of a second injury on that side or on the other. What do you think are actually the things that are...
It's so hard. To me, I feel like they're two separate things. Like, they're not the same. I feel like a lot of people return to performance and still get hurt. So this whole primary and secondary injury prevention thing is so hard. And I don't think anybody knows the answer to that. There's things we know we definitely shouldn't do if you go back before 6 months, or like do something really dumb. But you can get somebody full back to performance and still get hurt. So I'm not sure we fully know what the recipe is to prevent injury. It's like they have shown that stronger people are more likely to get hurt. But it's like those are the people going back to sports. So I think if you're going back to competitive sports, there is an inherent risk because you've had it before that you're going to have another one. And I don't know if that's more so the people that have an anatomical predisposition for it. They've got a shallow groove. They've got who knows what. Maybe they're just predisposed to having an ACL. They've got a genetic history, whatever. I don't know. I'm more concerned of me getting you back to performance and just like burning some sage, hoping that you don't get hurt again. And just like informing you of the risk of going back. But I think as far as performance goes, oh gosh, yeah, I don't think our current return to sport does a great job of deciding who is ready to fully return to their previous level of performance. Maybe that you're ready to start reintegrating back into your sport from a competitive level. But yeah, I think performance has, oh gosh, yeah, that's really hard.
I ended up writing an article for E3 in March of this year, trying to figure out if can that question be answered? Like, I had enough patients in the clinic asking like, how do I reduce the likelihood of a second tear? Or like, what is the chance of me re-tearing? And the more I like dove into it, the less certain I was of, less confident about just this kind of like 90% being like a substantial like change in risk reduction. Like you said, people that are stronger can re-tear, or there's higher re-tear rates because they're going back and playing their sport. And ultimately it's like accepting that you're going back, or if you're going back to a level 1 sport, that's a major risk, just with the chaotic nature of it, with the forces involved, with the frequencies and volumes that you're just going to be exposed to it. And the highest likelihood of tear or injury is prior injury. So you're already kind of working at a disadvantage there. And my confidence in like, we have to hit these hard values or these hard numbers, because as a clinician, this is how I feel. I'm super confident that this is going to like significantly reduce the likelihood. But it seems like those should be more framed from a performance standpoint. Like we want your knee and your system and your body to be able to like do these things and perform at the highest level. But is that actually like significantly dropping the injury risk?
Yeah.
Would you agree that it's just
because it's like the people who feel like they're ready to perform are going to play at a higher level. It's sort of like a catch-22 with, if I return you to performance, am I increasing your risk of re-injury because you're getting more playing time? You're getting, maybe in high school, now you're going to play in college, or maybe you weren't going to play in college if you didn't. But yeah, I think we've started to focus more on like, once you've met maximal strength and horizontal hop test performance, we're moving towards like resolution of rate of torque development, reactive strength index, and some of these more like explosive type activities that you're not necessarily picking up with maximal strength testing or hop testing. But is that going to reduce injury risk? I can't say, but it could let me know that you could probably perform at a high level, especially these high school kids. When they leave us, they are fitter and stronger than they have ever been in their entire lives, because they've just spent an entire year strength training uninterrupted, which is something they've never done in their entire lives.
Yeah, I was talking to, I have a 15-year-old female ACL that she's 5 weeks out right now. And I framed it to her and her mom of their understanding of this being like a 9 to 12-ish month process. And I said, my goal for you is you're going to be a much more athletic soccer player entering or re-entering soccer than when you injured it. And you're going to be in much better position just as an overall athlete. And they were like totally on board with that. And that's probably how it should be, especially for these younger athletes where their training age is minimal to zero.
They're such sponges. I call them anabolic sponges, because like they PR every week. I'm like, you little turd.
Totally.
What I would give for that. God.
But the question becomes, ultimately, as a clinician, what do you suggest, or what is the advice for like, when do you recommend a full clearance for return to sport? Like, should there be hard metrics of, if you don't pass this, then I don't recommend you going back? Or if it's not this timeline, like how do we embrace that like uncertainty while also having some kind of barriers and boundaries and guidelines to suggest to the family and to the patients, let's rock and roll, you're discharged from PT and you're fully returned?
So we currently still use like your standard, like 90% strength, symmetry. I'd love to see you over 3 Newton meters per kilogram for strength. If you're just like a 2 Newton meter person, then you just are like, some people train for a year and they're just not very strong, and that's fine. But I'd like to see you symmetrically sort of at what your ceiling is. Some people's is really high. Some people's is not as high, and that is just the world of genetics for you. So we look at strength for sure. We look at functional testing, whether that's hop testing. We do your classic hop test battery. To me, it's like more of a confidence thing than anything that I'm assessing. We look at your PROs. And when they've passed all of that and a minimum of 9 months, we have the conversation of like allowing you to start integrating back into competition with either some restrictions. Like we have a volleyball player who's a setter, And so we're having her just do back row set so that she's not playing at the net right now. And she played a full tournament this last weekend. So sort of like you're cleared to start doing things with your team competitively with the knowledge that there's still work to be done and that you're probably not going to be playing at your previous level of performance, because we are also testing all of these other variables. We're just not necessarily using that to put start and stop, because I don't have enough evidence to say if your RTD is not symmetrical, you're at risk. So I'm letting people go when they passed our traditional testing, and then often sending them programming to continue on kind of training these other more performance type qualities.
Yeah, that's what I noticed in my prior clinic, where fortunately we had phenomenal access in a private practice to an isokinetic machine. We had a HUMAC. We had Vold force plates. We had, just general dynamometers. And it was just like we could have gotten rate of force development, rate of torque. We could have had reactive strength, or whatever those like jump metrics are. Mm-hmm. And it's almost like you can collect so many things, and you can almost always find deficits, because in asymptomatic, healthy, athletic individuals, there's going to be some level of variation. So how much variation are you comfortable with? At what point do you call this more of a performance test and metric that you, like you said, you want to improve from a performance standpoint, but you're not holding them back from a injury risk standpoint? And I think that gets messy. And when you have more and more technology and more stuff's coming out about like how cool some of these testing pieces are and what you could test and what you could find, it becomes hard as the clinician to know, where do I prioritize my time and energy? Yeah.
I think you hit the basics, which no one's really doing. Just strength symmetry, normalized strength. I mean, you're like in the 99th percentile if you're considering that. They passed their hop testing, and you've done a good reintegration back into competition where you've taken all those steps where it's like you've done skill work, you've done practice, you've done non-contact, and you're doing all of that leading up to them passing and then reintegrating back into sport. So, I mean, you'll know when someone's ready, and that sounds so cliche, but like, well, some high school males will think they're ready like 8 weeks post-op, but typically you can feel like when you put somebody through certain workouts or you ask them to do certain things, like you can just tell when somebody's confidence and physical abilities is at a certain level to where you feel comfortable with them maybe doing certain tasks, certain skills. And it's very sport dependent as well. Like we had a level 10 gymnast where like for her, maybe things like reactive strength index and RTD are going to become a lot more critical because her entire sport is, reactive strength. Or we have a triple jumper, a long jumper, versus we have a lineman who I'm sure it's important, but he doesn't need to land and leap off of his leg repeatedly. He needs to be like an isometric horse out there. So yeah, it's complicated. There's not a right answer, but I think that's where having a lot of reps and a lot of knowledge of what your patients need to do becomes important. Or like the risk benefit, like what year are they? Is it important that they get back to their sport? Like we've had someone who was maybe high 70s for strength. Norm strength was above, but she was a little asymmetrical. It was her last soccer competition she was ever going to be able to participate in. She met the time, she met everything else. And it was like, this is the last tournament I'll ever play in my life. And we're like, I mean, it's up to you. We've told you the risk, but if it's important to you, I'm not going to hold you back from doing it. So
yeah,
there's a human under testing that has to be taken into consideration as well.
Anything else that you want to touch on before we wrap up? We're almost an hour, but anything that you feel just less certain about that you were super confident in starting the program, or just overall reflections as you're nearing the end that we haven't discussed yet?
Yeah. I think the biggest takeaway is like, we don't know a lot. I think we're doing the best we can with the tools that we have. But yeah, I think ACL Rehab is over a year-long long process, and a lot of clinicians are only seeing a brief snapshot of it. I think it's a long process, and you've seen one ACL means you've only seen one ACL. Everybody's different. And I'm hoping that research, either from me or other people, is going to continue to be more like clinically salient and help with this, like discriminating between return to performance and re-injury risk. So that's sort of my long-term goal, is to try to suss that out. But
love it. Well, we'll link the PTN Quest, the podcast. Any research papers that you want to kind of highlight that you've published recently that you want us to include as well?
I've got one that's been in limbo forever about RTD testing, so be on the lookout for that. I have one in IJSPP that not very many people have read. It is difficult to get access to because I don't know why you just can't read any other papers, even if you have a university link. But it's looking at basically the difference in testing rate of force development, closed and open chain, and sort of the nuance behind closed chain versus open chain strength testing with ACLs. So
nice. Well, I'll find it, or you can send it to me and we'll link it and try to get people access. And then if they can't find it, they'll just probably email you.
Please.
Megan, this was great. I appreciate you chatting, and we went in a variety of directions, but that was kind of the goal, just to see what all is shifted for someone that loves ACLs, worked within that population prior to your PhD, and now is in it. And the fact that you have this like clinical access and frequency and volume still in your PhD is awesome. All right, Megan, thank you again. We'll call it there.
All right. Thanks, Chris.